I welcome all for this morning, first session of this morning, the third day of the conference at Kochi. So, in this, we are basically discussing the various aspects of glaucoma drainage devices, basically a video-based course, and in mainly in the various challenging situations. So, I have the privilege of giving introducing my co-instructors, Dr. Vinitha Gupta, additional professor at the AIMS Rishikesh, and Dr. S.S. Pandav, the chairman of the Advanced Eye Center, PGI Chandigarh. And I have Dr. Suresh Kumar Gupta, the head of the department, Government Medical College, Chandigarh, and Dr. Srishti Raj and Dr. Sushmita Kaushik. Madam will be joining soon. So, so I'm not wasting much time, going directly to the presentation. I invite Dr. Vinitha Gupta to talk about the basic introduction and indication and general consideration for glaucoma drainage implant surgery.
Ayani? Good morning, everyone, to this early morning breakfast session. So, as Dr. Faisal has said, I'll be talking about indications and the general considerations for glaucoma implants in the management of glaucoma. So, what are these glaucoma drainage implants? We all know these are the devices which basically drain or divert the aqueous from the anterior chamber into an external reservoir, which is usually the subconjunctival space. Uh, the drainage doesn't start immediately. Obviously, it depends on the type of implant which we have, but basically the process starts with the formation of a fibrous capsule about 4 to 6 weeks after the surgery, which actually regulates the flow of aqueous from the anterior chamber to that external reservoir. So, where are these implants used normally in our practice as a glaucoma surgeon? It is basically mostly cases of previously failed trabeculectomies, and those cases where there is a complicated look of the eye with scarred, extensively scarred conjunctiva, and or insufficient conjunctiva for a trabeculectomy to be done. Or there are certain situations where complicated glaucomas or difficult cases of glaucomas where I would say they may be the first line of choice as a surgery. So all these glaucoma drainage implants have a basic design of having a tube and a plate, end plate, that with difference in sizes, difference in the material of the end plates, and they're basically classified as two types based on the presence or the absence of the valve which is there. And how do they operate? Basically, what is happening, this video is not playing. Anyway, so what is happening is basically what the aqueous humor is going through the silicon tube to a reservoir, which is outside the GDI plate, which is formed by the encapsulation occurring over a period of 4 to 6 weeks, I said. Aqueous humor from this space then goes into the actually gets absorbed into the lymphatic vessels and the tenons, passing through the tenons and the conjunctiva, which has the part of that fibrotic capsule, which has formed around the end plate and is absorbed from the capillaries out there. So with the advancements, there have been in the development of these glaucoma drainage implants, there have been now with these drainage surgery, we're able to achieve greater success, lower complication rate, and we are able to facilitate implantation in an easier way with improved IOP control and a reduced incidence of acute postoperative hypotony. So if I classify them as I already said earlier, they are null valve, which basically require a temporary restriction for the initial 4 to 6 weeks by an internal and external ligation. And we have the different types, Beerwell, the Indian prototype of which is the Adi, and the Molteno, which is usually a double plate implant. Depending on the surface area, they have different sizes. The basic advantage of these is basically they have a larger surface area of the end plate, which acts as a reservoir. So a better or increased IOP lowering effects are there. And Adi is the low-cost version of the Beerwell implant. Disadvantages, obviously, there's a delayed time before actually it starts functioning. It's a larger size. There's a greater risk of diplopia because of the being placed under two different muscles, and a greater risk of hypotony if immediately we release the sutures or if we do not do that ligation. And more intensive follow-up is therefore required for these cases as compared to those for valved implants, where we have the prototype is the Ahmed valves, or the Crippen valves are the other types. Basically, again, they have silicone or the polypropylene is the basic material. The advantage is the immediate post-op lowering of the IOP can occur as soon as the surgery is done, and they are placed in between the recti, so they do not cause much of restriction of the muscles, and post-operative diplopia is not there. And obviously, the risk of immediate post-operative hypotony is also not there, because the regulated flow occurring because of the unidirectional valve functioning there. Although have the disadvantage that there may be a high rate of bleb encapsulation leading to late fall in the a late rise in the IOP. So now let's look at the indications of these. As I said, high IOP despite your maximal medical tolerated therapy and a prior failed glaucoma filtering surgery with the use of even antifibrotics. Or, as I said, cases of complicated and difficult glaucomas, which includes cases like aphakic glaucomas, those of neovascular glaucomas, those of refractory childhood glaucomas, those with uveitic glaucomas, or maybe after post-keratoplasties or post-vitrectomies. Other difficult cases of glaucoma are those with aniridias, those with Sturge-Weber syndromes, those with ICE syndromes, those we have excessive epithelial fibrosis, like in cases of post-chemical burns, post-cicatricial pemphigoid, all those cases. The cases where I would not prefer or go in for GDI would be eyes where there is severe scleral thinning, because I would not have a place to place these implants. Or there is an extensive fibrosis of conjunctiva where I will not be able to even create a space to have a reservoir for this end plate in cases of malignant glaucomas. The other two are not actually contraindications. Vitreous in AC, you have to be careful while doing your examination, and you will have to do an intravitrectomy so that the tube doesn't get blocked by it. And similarly, if there is a silicone oil, you'll have to change your place of implantation, which will be shifted from its preferred site of supratemporal to an infratemporal location in these cases, so that the silicone oil doesn't block the tube. So what are the preoperative considerations when we have to do such glaucoma implant surgery? A thorough clinical examination is important. On slit lamp, look for any neovascularizations. If neovascularization is there, it is always best to give a preoperative anti-VEGFs before you actually proceed with your surgeries. Look for vitreous in the AC, which I've already mentioned. You will need to do an intravitrectomy so that vitreous doesn't block the tube of your implant. Anterior chamber depth, you have to assess. Obviously, if there is anterior chamber depth, corneal touch, or AC is shallow, then obviously you will like to place the implant tube in the posterior chamber rather than in the anterior chamber. Gonioscopy again, pass may interfere with that. Lens status you have to assess, because obviously in the aphakic eye, the past plana approach, or in pseudophakic eye, in the sulcus placement of the tube is possible. Or if there is a dense cataract, you may even do a combined approach. So these are the cases where again you have to be more careful, because this will create problems while doing your surgeries with a deep set eye or a prominent nasal bridge. The choice of anesthesia obviously would be depending on the patient's systemic conditions. Ideally, a general anesthesia would be done in cases if there's comorbidities. Otherwise, you will have to give a block. These cases cannot be done under intracameral anesthesias. If you want an early IOP control and a long-term IOP control, so these are two things which we are looking at. So depending upon that, the choice of implant would be there. We would take up a valved implant if the IOP is very high and we not want an immediate IOP control. But if there is IOPs in late teens and we can do away with the small amount of continuation of medications for 4 to 6 weeks, then we can go for the non-valved implants. And obviously, the studies have shown that the non-valved implants also work pretty better, except that the complications are lesser with the, I'll just finish here, with the valved implants. And again, for mild to moderate damage, obviously the valve implants are better. For advanced cases, non-valve implant will do. Location-wise, supratemporal is the best location. So you have to take care that there is a good sclera, there is no vitreous. The size, implant location, everything is dependent upon the type of IOP control which we want. Function of the foot plate, as I've already mentioned, it is placed in between the two muscles in cases of non-valved implants because of the larger plate size. Patient compliance is also to be taken into consideration. Surgeon's experience and comfort is another important factor which allows us to choose. Beginner may prefer a valve device. Cost is obviously the factor in our country, where obviously we are using a non-valve ADI device has come into frequent practice and frequent use. For vitrectomized eyes, use a valve device because the risk of hypotony is higher. Similar is the case with uveitic glaucomas. Same is the case with the post-PK glaucomas, where we do not want the placement to be done in the past planar tube has to be placed in the past planar so as to avoid failure of the graft. And also in the cases of post-RD cases, obviously a larger implant will have more problems because we need larger area for dissection and already is a very, very cicatricial conjunctiva. It is already scarred conjunctiva. So on these cases, we prefer to go for a valve implants. Silicone oil filled, I've already discussed. For childhood, again, refractory glaucomas, long-term outcomes are not known, but yes, there are studies which say that in difficult and refractory cases, these will work. Past penetration I've already discussed. So this modifications I can skip, except for that we can even do for the non-valid implants, we can do a two-stage procedure. For if you want a initial IOP control, we can basically without entering the eye the first stage, and in the second stage we enter the eye when the fibrotic capsule around the end plate has already been formed. So just to conclude in the end, GDDs are very successful in controlling IOPs in previously failed traps and refractory glaucomas. They're available in different sizes, materials, and designs. It is the individual characteristics of the patient in regards to his preoperative IOP, his optic nerve status, his desired long IOP control, and the surgeon's comfort and experience, which all decide which type of implant we have to choose. And numerous modification techniques have helped us in choosing these. And therefore, a careful preoperative screening and planning along with meticulous surgical technique can help in minimizing all the complications, which were thought to be very, very uh, dangerous earlier when we were not doing the implant surgeries. Thank you.
Thank you, ma'am, for giving a broad overview of the general indications and considerations pre-op workup. Now I invite Professor S.S. Panda for showing about these various tips in GDD in eyes with pre-existing scleral buckle. It's a very tricky situation. The most difficult, I can say, most difficult situation to put a drainage device implant in a pre-existing scleral buckle. Please, sir.
Good morning. Give me the mic, please. Good morning, everyone. Yeah, and thank you, Faisal, for including me to the program. I'll take you through quickly through the some difficult situations. Slides not moving. Yeah, can you please give me the presentation? Yeah, okay. Glaucoma drainage devices are required in some of the most complex situations because the normal cases there are other alternatives available, but when there's nothing else works, we usually think about drainage devices, and particularly post RD surgery when there's a big buckle, post vitrectomy eyes, post silicone eyes, distorted anterior segment because of trauma, repeated surgery, inflammation, and a number of other conditions where routine glaucoma surgery is not useful or is more likely to fail. This is one example of a 26-year-old male patient who was high myopia, had retinal detachment, and underwent complex surgeries. And you can see uh, the eye is already operated a number of times, and there's a buckle there that you can see when we dissect it. So idea is basically you can dissect these eyes, still you have to be careful. And there's a buckle there, so I am here suturing the implant with the buckle itself because that's located in a position where the implant has to go. And so this is an ADI implant. So ADI implant is usually difficult to place in eyes where you have a buckle, but this was a band, uh, and you could suture it to the band and uh, nicely uh, put the plate in position. And once the plate is placed in position, because this is a non-valve device, so it has to be the tube has to be ligated. And once the tube gets ligated, the rest of the procedure is actually simpler. You can just uh, then you just have to insert the tube in the anterior chamber, and it's like any other standard GDD device. This is a very old patient we did. This is following trauma. This is the only eye the patient had multiple surgeries, large buckle there. And this was a time when, ADI was not actually available to us. So this was the bare welt implant which I got for him. And similarly, in this patient, buckle was a little anterior and so large, so I had to go a little behind the buckle and complete fix the buckle there, and put the tube in the anterior chamber. And as you can see here, I have used a different technique to ligate the tube. uh, I'm using a stent suture to ligate the tube. That's the idea is that this gives me some flexibility in the post-operative periods if I want to if the pressure really goes up and want to release it. But as you can see, the rest of the surgery is like any device, and because there's nothing in actually in the anterior chamber or the posterior chamber, so placing the tube is not an issue here. The main problem is the fixing the tube and this plate, and this is 10 years later actually the single-eyed patient, and he is maintaining 3 by 60 vision, which is ambulatory vision, and IOP is 18 to 20 millimeters mercury with 2 anti-glaucoma medicines. So I think uh, even now the patient, the follow-up is now actually 15 years, which is, and he's still ambulatory, still doing fine. So in some of these desperate situations, these valves are really good. So how well the GDDs do in glaucoma post vitrectomy? I think we had looked at our data a couple of years back of 78 eyes, and this has also been published. And most of our eyes were trauma recommended in RD with complicated surgeries and followed up for 24 to 180 months. So there's quite a long follow-up. And as you can see, the AGB in post-PV eyes actually does well. This were mostly AGB. Most of the cases were AGB, but we also have few others as well. And you can see the cumulative probability is almost over 90%, which is again very encouraging figure. And if you look at the IOP reduction and reduction in the anti-glaucoma medicines, as you can see, both are significantly reduced from the pre-operative or before surgery situations. So in complex situations like this, tubes are really helpful. Now, sometime if you have a large buccal and uh, if you want to place a tube, it might be difficult to place another implant there. So and if the tissue is too scarred, then also because putting another big implant there is difficult. So in that case, you can just dissect it gently and identify uh, the capsule which forms around the buccal. And this is a silicone tube which is normally used for was the same diameter that is used for the implants. And what we can do is we can just insert the silicone tube into the capsule which is formed around a buccal. This was a 377 buccal which retina people use, and you just feed that tube into into the capsule around the buccal, and ligate. You don't ligate it because, but you anchor it, firmly so that without occluding it, and then rest of the procedure is like that. And the important thing you have to do is that before you insert the tube into the anterior chamber, make sure that you inflate and the capsule around the buccal with BSS so that there's no sudden hypotony. And this is after surgery. This was placed inferiorly. You can see the tube is very nicely placed, and there's a 3 weeks. The IOP is very well uh, controlled. To summarize, the presence of buccal makes surgery very difficult due to extensive scarring, adhesions, previous surgeries, presence of space occupying structure already there in the orbit, and you want to add something more to it. This becomes difficult. And also, but it is possible to implant glaucoma drainage devices in these eyes, and you can have a good IOP control, and some of these eyes can actually you can save vision in them. Thank you very much for this opportunity once again, Faisal.
Thank you, sir,
Thank you.
and finishing by time, and also a very nice demonstration in difficult situations. And sorry to the audience for the technical glitches happened. So now I welcome Dr. Suresh Kumar Gupta. He is currently an HOD of the Government Medical College Chandigarh, and he will be talking about GDD in a refractory GDD glaucoma in post-keratoplasty. And we know post-keratoplasty, there are multiple reasons for developing glaucoma. Most of the cases have a 360 degrees INECA also, and there is some tricky in doing these surgeries. So I welcome sir once again. Go ahead with the presentation.
Thank you, Dr. Faisal. Good morning, all. And at the outset, I am grateful to Dr. Faisal for including me in this program. And I'll be discussing glaucoma drainage devices in refractory post-keratoplasty glaucoma. No financial disclosure. Any rise in intraocular pressure after penetrating keratoplasty with or without associated optic nerve head changes or visual field changes constitute post-keratoplasty glaucoma, and its incidence varies from 90 to 31% in early postoperative period, increasing to 18 to 35% in late postoperative period. It's quite prevalent, and it has become second leading cause of graft failure. And risk factors for having this post-penetrating keratoplasty glaucoma is having any form of pre-existing glaucoma, maybe POAG, PACG, or any rise in pressure because of either perforated corneal ulcer and adherent glaucoma, ICE syndrome, or patient has undergone keratoplasty in the past, or patient has undergone keratoplasty for pseudophakic corneal edema, or cataract surgery is done as part of keratoplasty, or patients having trauma. All these eyes are more predisposed to have post-penetrating keratoplasty glaucoma. So the mechanism can be open angle, angle closure, and but in most of patients it's combined mechanism. And it's a diagnostic challenge, especially in eyes with opaque cornea. When measurement of intraocular pressure becomes difficult, optic nerve assessment as well as visual field analysis is difficult, and angle assessment also becomes a little difficult. So IOP assessment, especially in eyes with showing irregular Myers on Goldman applanation tonometer, you can go for tonopen or pneumatic applanation tonometer, or currently DCT can also be useful in these eyes having more corneal thickness. Angle assessment, if cornea is opaque, you go for UBM. UBM is useful in assessing the angle and in establishing the mechanism of glaucoma, and it's also useful in eyes when we are planning glaucoma drainage device, because if we find a large synechiae in one particular quadrant, don't put device in that, go to another quadrant. Or it can also be used to look uh, at the tube after postoperatively if cornea is opaque. So though UBM scores over anterior segment OCT, but it has the advantage of being non-contact and can be useful in certain cases. Optic disc evaluation is another issue in especially with opaque corneas, and then ultrasonography can help in evaluating the optic nerve head damage. So in one of our departmental study which has been sent for publication, we correlated. We had two groups, in one with clear media where disc was seen with 90D lens, and in opaque cornea we did ultrasonography, and we found very strong correlations in disc with cup disc ratio more than 0.4. So management is another challenge in managing in these patients. So medical management is given till patient is waiting for surgical procedure, and we avoid myotics and prostaglandins in these patients. Laser iridoplasty or laser iridotomy can be useful in patients having significant secondary angle closure. In surgical management, trabecular colectomy with mitomycin C was found to be useful, but with the advent of glaucoma drainage devices, they have become mainstay of surgical management of these patients. One of our departmental study, though small and preliminary study, but it found trabeculectomy with mitomycin C useful in these patients. And now with glaucoma drainage devices, in literature we have found that the success rate is much better with GDD as compared to trabeculectomy with mitomycin C. But the main area of concern in these devices is corneal endothelium and endothelial decompensation. So the list of complication, Professor Sushmita Kaushik will be dealing with them in detail. I will be just focusing on graft failure. So graft failure has been found to the tune of 10 to 31% in these eyes, and one study found that there is 60% reduction of endothelial cells within 2 years after the surgery, which is very, very, I mean, serious issue. So one study found that distance between tube tip and endothelium, it was the most important risk factor for damaging the endothelium. And logically, if we keep the tip of the tube away from the endothelium, it will be protective for the endothelium. So one of our departmental study which has been accepted for publication in Indian Journal of Ophthalmology, it's a retrospective case series of 66 patients in which 43 patients underwent ciliary sulcus implantation of tube as compared to 24 patients in anterior chamber implantation, and we found that intraocular pressure was similarly controlled in both the groups, but the corneal decompensation was significantly higher in anterior chamber group. So we advocated use of tube in the sulcus wherever possible, like patient having aphakia or pseudophakia, especially in post-penetrating keratoplasty glaucoma. So a small video showing AGV implantation in post-penetrating keratoplasty glaucoma. So I prefer AGV or valvular device in these patients because you have good control of IOP in the immediate postoperative period. In non-valvular devices, the IOP has to be controlled with medication for at least 6 to 8 weeks after the surgery. So doing priming has to be very gentle in valvular device, otherwise valve will be damaged. So then after priming, it's put in the pocket created for the implant, and then it's fixed to the underlying sclera with 9O or 10O nylon suture. So paracentesis is done for anterior chamber manipulation for putting viscoelastic, and then it's being fixed to the underlying sclera. So since it's a non-valvular device, we don't occlude the lumen, but tube, I always anchor to the underlying sclera. This keeps the tube in place. So viscoelastic is being put. Now a track is being created. Since this is pseudophakic eye, I'll put the implant in the sulcus. You go 2 millimeter behind the limbus and then create a track, and you see the needle within the anterior chamber, and now tube is being cut around 3 millimeters. Since it's going into the sulcus, so it has to be little longer. So then rest of the surgery is same as we do in other cases. So few of our patient in the postoperative period, tube in the sulcus. So concluding my talk, post-penetrating keratoplasty glaucoma is fairly common problem, and it poses several diagnostic and management challenges to the ophthalmologist. Glaucoma drainage devices, they offer good control of intraocular pressure in these patients, though endothelial decomposition is one of the major issue. So tube in the sulcus in eyes wherever possible, like in pseudophakic eyes, will protect corneal endothelium. Specular microscopy is important in postoperative period. You pick up damage to the endothelium, then change. If tube has been put in anterior chamber, you can shift in to the sulcus later on. And these patients, they need aggressive and prompt surgical management to save vision. Thank you.
So very good morning, everybody, and thank you all for joining this. So I'll be discussing if you have patients of cataract and the refractory glaucoma, basically how will you manage with two. So I will be discussing combined GDD in emulsification refractory glaucoma. As we know that cataract and glaucoma frequently coexist, and both are tended to be the diseases of elderly people. So how will you manage? We can start medical management, failing of medical management or previous trap, failure of the medical management and progression with medical management will require a surgical management. So what are the surgeries you can offer? Combined cataract extraction along with trab MMC or sequential surgery. That's another debatable topic. Potential advantage of a combined surgery are early visual rehabilitation, and combined surgery reduces the cost and reduces the psychological issues related to multiple surgeries to the patient. So the problem is in refractory glaucoma. What we do the refractory glaucoma along with a cataract. So one can do a phacotrabeculotomy and MMC, but it have known to a poor result of the refractory nature, mostly like in secondary glaucoma especially. Another potential alternative is to combine the phaco emulsification with glaucoma drainage device. So I'm showing after a good thorough workup, as we do routinely in the clinic. So I'm showing two videos. One is phaco AGV and one is phaco ADI. The first one is the phaco AGV and the second one is the phaco ADI. Start with the as we start normally. Make a broad conjunctival peritomy at supratemporal quadrant. Arrest the bleeders and hook the both recti muscle, especially for the implant. And for AGV implant, one has to check the one have to prime the implant very slowly, and one can both have implant has to be fixed to this under the sclera. We usually prefix the suture, then fix the implant to the sclera. So Adi, sometimes that will be difficult. You need a good assistant to assist these type of cases. And once you fix the tube, now you can go with your cataract surgery. As we do routine, in first case, there is synechiae, so I record and mydriasis by using iris hooks. So whatever technique you feel like you can do, whatever chopping technique, whatever you are comfortable that can be used. Depends on case also. If it is soft, that we usually do a direct chop. Then the carry with your normal phaco like nucleotomy and emulsification of the nucleus. Once you finish the nucleus, go with hydrodissection as we usually do in routine cataract surgery. And be careful about the chamber because the already complicated cases most likely have synechiae and have more chance for hypotony also. Then put the IOL. After putting the IOL, inflate the AC again with adequate amount of viscoelastic. Then make this scleral entry. You can put the if you have synechiae there in supratemporal port, and you can fuse this the ciliary sulcus also, preferably ciliary sulcus, and once you put the tube, the rest of the steps is like similar to your routine GDD implantation. So at the end of the surgery, you have to remove the viscoelastic. Some people make the tunnel first before performing the cataract surgery and then leave the tube outside. Then after completing the phaco, we'll insert the tube. So these are the pre-op and post-operative picture. The first AGV patient had required more medication with 16 millimeter of pressure right now after 3 to 6 month follow-up, and the Adi patient performed relatively better with 12 millimeter of pressure with single anti-glaucoma medications. So complications, as we know, more usual complications like hyphema, fibrin, shallow AC, and sometimes corneal edema, and all the complications related to GDD like tube exposure and patch graft exposure and plate up. These are the possible complications. What the literature says that the various studies found that around first study that shows 89% at 18 months with combined cataract extraction with the Barwell implant. Most of the studies are did with phaco with AGV implantations, and the Singapore studies showed there's a cumulative success of 87.5%, and they have only 4 failure. The other study found that they have a 11% of complete success and 89% of qualified success. What was Indian study? Dr. Vanida Patak conducted a study. They found that the overall success was like 89.5%, and they also had minimal complication is in 36% of the patients. Another studies also found the phaco with Adi in refractory glaucoma. They also similar kind of cumulative qualified success like 17.4% at 3 months with a short-term follow-up only, and 64% at 3 months onwards. So I conclude, cataract and glaucoma coexist as the disease are elderly patients, and TRAB may not be a viable option in all patients. Can combine with vacuum-emulsification with GDD. Early visual rehabilitation is possible with combined surgery, and also the supporting evidence also suggesting as a relatively good outcome of these combined surgeries. Thank you. And now I invite Dr. Srishti Raj sir for giving a talk about this refracted GDD in uveitic glaucoma, because uveitic also there's difficult situation. Sometimes the patient can have hypotony, then some high IOP. Following the surgery also very high chance for even chronic hypotony.
Good morning to all. Thanks to Dr. Faisal and organizer for giving me an opportunity to present my talk. I have no financial interest. So I'll be talking about GDD of choice in refractory uveitic glaucoma. So these are the various indications for drainage devices. So today I'll be talking about uveitis glaucoma. Apart from this can be done as a primary stent also. So what are the challenges we face in glaucoma surgery in uveitis patient? So uveitis reduces the success rate of glaucoma surgery, more likely to scar and fail, and there is more chance of hypotony, and it can flare up the inflammation, and it can also initiate or worsen the cystoid macular edema, and high to low syndrome due to recurrent uveitis cycle. There can be ciliary body inflammation and ultimately leading to atrophy. So care must be taken in planning and timing the surgery to minimize the risk and maximize the chances of success. So there are two mechanisms of glaucoma: closed angle due to synecdoche or pupillary block or neovascular glaucoma, or open angle seen in steroid responders, or clogging of the TVM with cells, fibrin, or inflammatory debris, or chronic trabecular meshwork damage and scarring of the outflow channels. So pre-operative consideration should be given a consideration. As far as possible, wait for inflammation to settle or it is minimal. Maintain intraocular pressure on diamox for few weeks for inflammation to subside, especially when the optic disc is also not bad. Add oral and topical steroid 1 to 3 days prior to surgery. If the patient is steroid responder, you can add topical non-steroids also. In case of viral uveitis, add antivirals 1 to 3 days prior to surgery. So what are the options we have in uveitic glaucoma? So we can do external stents or trabeculectomy. Lasers and cytophotocoagulation are usually not considered. So intraoperative considerations: avoid multiple entries into anterior chamber and minimal and gentle handling of iris or uveal tissue. In case of synecdoche, prefer large CI so that it is not blocked tube and is not blocked by the iris tissue. Since the conjunctiva is friable, so it's better to use non-tooth forceps, and also there is fibrosis. So there may be difficulty in making the dissection. So take care of scleral flaps. So there is no button holding. You avoid tooth forceps and avulsion and cheese wiring of the suture used. And at the end, make it sure that there is no to avoid hypotony. There should sutures should be tight, and if AC is shallow, make sure that you leave some viscoelastic into the AC. So basically, the steps of the surgery are same as in any routine GDD, but some of the pre-op consideration which I discussed should be taken into consideration. Make a liberal flap, and as far as possible, use the non-tooth forceps or hold the tooth forceps, hold the tenon with tooth forceps whenever possible, and take care that there is no button holding of the conjunctiva. And usually we prefer the same quadrant, that is temporal quadrant, unless there are fibrosis and synecdoche, then you can go for spironasal also. And after creating the flap and deep pockets, we can place the plate. In case of this is the what I am showing, this is the AGV implant. This is placed between superior rectus and lateral rectus muscle. Since its width is small, in case of Vadi, you have to place it under the wings are placed underneath the superior rectus and lateral rectus muscle. The rest of the steps are same, but since it is usually associated with synecdoche, and in pseudophakic patient, you can place the tube at the side of previously CI or in the sulcus, but make it sure that the end of the tube is visible. So in case of anterior synecdoche, make a large CI so that its end is visible, and also it is not blocked postoperatively by the iris tissue. So post-op period is also very critical in case of uveitic glaucoma. So aggressive anti-inflammatory drugs are used in post-operative period to control the inflammation. It's better to give a IV bolus of the steroid immediately in post-op period, and frequent topical steroids used with tapering and titrating against the amount of inflammation. Also use the non-steroidal anti-inflammatory for prophylaxis of the CME and give strong cycloplegics. So in case of, if the patient is already having steroid implants, post GDD inflammation may be less, but there is some delay in wound healing that may be impaired. So late wound resistance can be expected. So as far as toys of GDD is concerned, these are classified based on the type of the plate or type of the material or type of the opening. So it can be rigid or flexible based on the type of the plate. A material can be of silicon or polypropylene, and tube can be valvular or non-valvular. So GDD, this is the chronology development of the all the implants, Molteno, then Krupin, then Barbell, then AGV, and last was the Adi, which is basically the prototype of the Barbell only. These are the various designs of the various devices used. So we can expect complication. So hypertensive phase, that is seen more with the AGV or valvular implants, and there can be transient hypotony varying from 12 to 26% of the cases, but most of the time it settles down. Other complication can be encountered like end of migration of the plate or tube erosion. Diplopia is usually seen with barbell, almost 9% of the cases. So success of the implant varies from 17 to 79%, and maximum success is seen with Molteno DP plate. Other approaches, trabeculectomy can be undertaken in case the stent is not available, but SLT and DLCP are usually not considered because they themselves create inflammations. So these are some of the problems with TRAB, why it is not prevalent in inflammatory glaucoma, early failure, post-op infections, or shallow AC or choroidals. So this was the retrospective meta-analysis done by Ramdas et al. Efficacy of GDD in uveitic patient was compared against the GDD in non-uveitic patient. So the intraocular pressure control was similar, only the macular edema and hypertony was seen slightly more in uveitic GDD, though this was not significant. And this finding also corroborate with the previous reports. So in conclusion, GDD in uveitic patient, success rate is almost similar to the non-uveitic patient. Hypotony is slightly more than the non-uveics, and cystoid macular edema is also more than the non-uveics. Control of inflammation prior to surgery is very important and crucial to the success of the tube. And minimal iris and uveal tissue handling during the surgery. And consider large PI if there is a lot of synecdoche. And if pseudophakic patient, we can consider the placing the tube in the sulcus. Aggressive anti-inflammatory therapy in the post-operative period is mandatory. Thank you.
Thank you, sir, and for wide elaboration of the management of uveitic glaucoma with tube. Now I welcome Professor Sushmita Kaushik. As we know, nothing is complication-free in our surgical time or in life, but she will be discussing about how to manage various complications related to GDD implants. Welcome, ma'am.
Thank you so much, Faisal, and for including me in this lovely course. And thank you, AIOS. Uh-huh.
So as we know, for uveitic cases, the main concern is the one is the chronic hypertony, and one is the how to put the tube. The tube should not touch the iris. If you constantly touch the tube, the iris, there is high chance for recurrence of the inflammation. And try to do as much as AGV is in uveitic glaucoma, because they have many patients. My experience, we have seen that there is chronic hypertension. Sometimes the patient can present even after years after the GDD implantation. So that is the one tip. Try to do AGV as possible, as much possible in case of uveitic glaucoma, and put the tube away from the iris, in case of puberty glaucoma. And post PK glaucoma, sir has already demonstrated, is already shown his data also, and found that the endothelial loss is the concern. So they put the tube in sulcus if possible, especially in case of all pseudophakic cases, or if the patient have a iridectomy, that just put the tube in that iridectomy area. So, or if not possible, maximum away from maximum posteriorly from the endothelium. That so in post PK, the endothelium loss is the major concern for during GDD
Sure.
implantations.
साइंटिफिक खोलो कौन सा खोल दिया तुमने पीछे जाओ पीछे जाओ हाँ ठीक है साइंटिफिक
So if any questions, we can take just one question in between.
Dr. George was saying something to put one suture in the implant. Can you elaborate on that?
That which sutures that
वीडियो चलेगा
stent sutures like yeah, the ripcord type. Yeah, you want to say the ripcord? Yeah, now the you can put the like on rip. They're coming with the ripcord sutures and put the ripcord suture into the lumen, and you can then but you have to ligate the implant as we do normally, and you can remove this ripcord. The external part should be the posterior part should be the under the conjunctiva of the about for this ripcord, and you can pull this once the pressure get stabilized, or if you want to open very early, or you just pull out these sutures, uh, preferably in the OT procedures. Don't try to from the slit lamp. Some people are using the slit lamp also, but you have to remove from the in the as a OR procedure. Now the Adi is coming with the ripcord also.
Right. I'm so sorry. Somebody else's presentation was in that folder today. So, right. So, we'll be talking about challenging complications after glaucoma drainage surgery and a few tips of management. They're all uh, individual. Once you start doing, everybody has their own way of dealing with these complications. These are just our perspectives. So, the complications could be an exposure of the tube or the plate. So, this is very distressing to see when it comes, but it does happen. Once you're going to put in your tubes, be ready to face these horrible exposures. Then you can have tube complications. You can have a corneal touch, or you could have a tube which for some reason is too long. You can have infections, you can have inflammation, you can be faced with endophthalmitis as for any other surgery, and there could be hypotony as well. So the principles of management for exposed tubes and exposed plates, they need to be repaired immediately. There is no wishful thinking that this problem will go away on its own. Typically, as a dissection of eroded conjunctiva, a placement of a dual layer of coverage, either a sutured patch to cover the exposed tube and a conjunctival overlay. But if you think the conjunctiva is not enough, you might have to have autografts from either the same eye inferiorly or even the other eye. So this is a patient who's come with the tube exposure. So she's received a scleral patch graft over the tube as well as a conjunctival overlay, and this is about a month or two later, and she's all right. So my slides aren't moving. Yeah, okay. So this is another one. Sometimes you have an exposure which extends onto the plate and the sutures. Again, you need to give an overlay and cover the area before any infection or anything else develops. Sometimes you might have to use a free conjunctival graft or even double layer amniotic membranes under the conjunctiva to give an additional layer. And at times we've also used buccal mucosal implants because they're one-eyed, the other eye is thicical, there's no conjunctiva at all. The idea is, so that's what a buccal mucus membrane looks like. It looks a little thicker, but at least it covers the plate and it's better. So coming to the problems of the tube, if it's a corneal touch, then you need to reposition it, or there's something that we've also looked at, which is a tube sling. So sometimes you won't want to go in and you would like to do something less invasive. If it's too long, then you need to cut it. If it's too short, you'll just have to take it out and try and reposition. And sometimes it disappears, and then you need to seek and recover and find it and get it back in place. So we look at some of these problems. This is a typical tube corneal touch. Now, if you already see the cornea, do you have a pointer by any chance? So if you see the cornea is already getting opaque at a point of the tube, and if you leave this, this cornea is going to decompensate someday or the other. So again, wishful thinking won't work. If you see this little thing here, you know this tube is going to cause trouble. So the best thing to do is take it out, and it was repositioned a little deeper, and then it does all right. And you can see the cornea there is much better after repositioning. Sometimes you need to reposition in a peephole. What that means is there is a tube corneal touch there. You can see this on the ASOCT. It is even indenting the cornea. So there's no point thinking that this cornea, this problem is going to go away. So since he had an absolute shallow AC and a shallow anterior chamber, what we decided to do is form a small peephole and reimplant it into the sulcus so that you could see the tube. So you see post-op, this is the tube here, it's behind, but for you to be able to see it post-operatively, you make a small iridectomy and you reposition the tube in the sulcus so that you could see it. And he's pseudophakic, so this can be done. Now there's another patient, look at this. So this is an iris which is tucking into the tube. Sometimes it might happen the bevel is too shallow. So here it is, this iris is tucking in and the pressures have gone up, and there's something that you need to do. But he's already, he's got good vision in the other eye, but neovascular glaucoma in one eye, ADI implanted. So you think, let's not go in all over again, because neovascular glaucoma with diabetics can be troublesome to fiddle in too much. So this is something which we tried, and sometimes it does work quite well. So this is something called a tube sling. It's a simple procedure to do. So the principle is that you just put in a sort of harness in front of the tube and pull it hard so that the tube just goes in. So it's a simple thing. You just take this, you go between the cornea and the tube and take this suture and just do a tight suture of a 9-0 nylon, because you need something thicker, but a 10-0 can be used if you want, but this is 9-0. And then you tie it in and you'll already be seeing the tube going a little back, and it can be behind the cornea. Then it's not touching it anymore. So there you are. So this is one day, and he stayed like that, but you're scared because sometimes this might, it's after all a conduit to the anterior chamber, isn't it? So at 6 months, we thought, let's remove it and see. And thankfully, it sort of fibroses and it stays that way away. And it works quite well sometimes if you can. So it's just short of a repositioning. If it doesn't work, we can go in and reposition it again. This was an interesting case, so I thought I'd bring it in. I dug it out actually. This 28-year-old man with trauma had a complicated cataract and retinal detachment. He had post-PPV glaucoma, and he had a scarred conjunctiva as well. The AGV was uneventful. So this is how he was for a while, and in 3 years, the IOP started rising. So these patients are going to be with you for life. And then when it started rising, we realized there's a bit of congestion there and there's no tube visible in the AC. So we tried a gonioscopy, there's no tube visible in the angle. So now you know that the tube has disappeared somewhere, and it's also causing inflammation there. So why should somebody who was completely quiet and all right come back with a congested conjunctiva and absence of tube? So obviously something has happened. So we thought we'll just have to explore it. And this was interesting. So it's a bit of a longish video, but so we started our exploration to seek and find. And you see there's no tube there. So it's gone down. So we're still finding. This was quite long. So I have cut it into many segments to try, and so still searching. And then we went under the plate and it's still not there. So it was quite amazing that where has the tube disappeared, and we're sure there was a tube there. So we took the plate off and came up to the plate of the graft, and we are still searching, and we know it's an AGV. And believe it or not, this entire plate had rotated, and the tube had rotated along with it, and it was curled up in the fornix along with the plate. So it was quite a surprise that, the tube can do anything, and we have no idea how it's retracted, it's gone up, it's curled itself against its plate. And my senior resident there at that time said it's like a baby going back to his mother. So we called it a fetal position of the. So there you see the tube. So the tube had gone up, and there it is. So you can see where the tube was. So it's a pretty longish tube there. There's no problem with that to reimplant it. But for some strange reason, it had just gone up, curled up, sat with the plate, and it was up there in the phonics. So that was interesting. This is the only case that has happened, that the AGV has just rotated on itself and also taken the plate along with it. So of course, it was just easy to reposition it. I just wanted to show this bit. So sometimes you have valuable lessons that you learn. So this 8-year-old girl with microcerophakia who'd already undergone a PPL had undergone an AGV, and now the right eye IOP started rising. So we decided to put in an inferonasal ADI. Now the pressure was 30, which is not unusual for an ADI because we ligate the tube. But what was worrying was this. So you have these vitreous strands which are going into the tube. And again, wishful thinking is not going to help. If we are not going to clear this up, this tube is not going to drain too much. So the lesson learned is even in a vitrectomized eye, so we assume she was PPL and PPV, or rather anterior vitrectomy, so the sulcus would be clear. But even with a vitrectomized eye, remember to do a skirt vitrectomy under the iris, because the vitreous might still be there, and the minute you put in your fluidics and it hydrates, it'll come up again. So be careful of that. So the easy thing to do, and you can see how early it is. We took the girl up again, even though it was a repeat GA, went in with a cutter. So since it was inferonasal, here it is, and look at all that vitreous around the tube. So we just ate all that up and did a good skirt vitrectomy to clear out the vitreous under the iris. And once the tube was cleared of the vitreous, now you can see how clear it is. Then the IOP stabilized and you could re-establish drainage. So the moral of all glaucoma, if anything, is look for a cause. It's not enough to just give Diamox to every glaucoma that comes to you. Look for the cause, try to treat what is happening, and usually that's what works. Of course, the most dreaded complication is endophthalmitis. It's something which we wish would never happen, but it's going to happen someday or the other. So you need to act promptly. There's no two ways about it. Invariably, we have to remove the glaucoma drainage device. I don't think we've tried at times, thoda sa hypopion hai, let's see, maybe we can salvage. We can't. The only thing that works is removing that foreign body there, because it's not going to let the eye heal. Intravitreal antibiotics culture the tap. Usually the infection is limited anteriorly, so there is a case for doing an AC wash rather than intravitreal, but we need to remove as much of the infective load as possible. So this is a turbulent journey. This 22-year-old girl with intractable JOAG and a failed TRAB had an uneventful ADI. 2 weeks later, she came to us with this, with hypopion exudates around the tube. We searched and searched in 2 weeks, but we found no dehiscence, no erosion, nothing to explain it. So it was quite disappointing for all of us. But immediate surgery, we explanted the ADI there. You see, it's a fresh conjunctiva, fresh thing 2 weeks ago, but we still took it out. And then daily monitored, the vitreous trap showed staph aureus, sensitive to vanco and cephalexin. There was no appreciable improvement in 3 days, and we were getting really worried because this hypopion just stayed where it was in spite of giving IV and an intravitreal. And then we realized the muck is anteriorly, and we haven't addressed that. So then what we did was took her up again and did an AC wash. We just removed all this stuff which was there, and then once the infective load was down, she was much better, and you can see she settled down well, and thankfully we salvaged her vision as well. So the take home points are, Tube entry should be as far posterior to the limbus as possible. That prevents erosions better. Cover the tube with a patch graft or a scleral tunnel every time. There is no case for not doing a patch. The cover should be parallel, the tube should be parallel to the iris. Ensure a long bevel and secure the plate nicely to prevent movement. I'm not sure whether that AGV with rotated was because the securing wasn't tight enough. Tell the parents to take care children don't press on the globe or rub their eyes too much, and if they do, they need to come back and address the problem. Thank you for the
Thank you for all, and we are already exceeding the time. I know you have a lot of questions. We can take the question. We are leaving this stage to the next sessions, and you can directly ask my faculties. They are already sitting there. So.